Okay, so just for a bit of an outline of the day, you guys are pretty used to Zoom platform now. The Zoom etiquette, I suppose I just wanted to remind everyone, we're not getting the chance to see each other face to face. So if you have got the opportunity to have your camera on, it's good for me as a presenter, but it's also good for each other just to be able to see each other. For the presentation, if you wouldn't mind just muting yourself, just because it does work better from an audio point of view. And then if you need to ask any questions, you're welcome to unmute yourself or use the chat. So we're going to just do an introduction to the AKT. I'm just actually going to do the same few slides that I started you off with last time, just because I've done the AKT and prepared the presentation and I still can't remember anything I'd written about. So I'm sure most of you won't be able to remember it either. And then Tom hopefully is going to have joined us with some better audio and we're going to hear his top tips. And then I've just written 50 practice AKT questions for you this afternoon. So for that, you'll need a pen and paper and a calculator, but that will be in the latter half of the afternoon for us to just run through some questions. Then you have an idea about where you are in revising for the AKT. And then I've just got your little task that I've set for you for your next CPD session. So before we go into it, I'm just going to do a little poll just to find out where everyone's learning needs are currently. Now let's get to the right one. So, okay, so you should be able to view those questions now, hopefully. Is that right? Yeah. So how many, question one, how many of you have attempted the AKT in the past? Question two, how many of you have started preparing for the AKT? And question three, for those of you that have started, what resources are you using? So just put some there. Are you able to answer those? Okay, so we're just waiting on a few votes.
So, you know, I don't think I can vote because I'm now a co-host.
Oh, okay, let me move you.
Sorry, can you resend it again? It's disappeared.
It should still be on your screen. Okay, Fran, you should be okay to do it now.
I can't see it.
Okay, so looking at that, so we've got 2 people who have attempted the AKT in the past and 15 of you haven't. 10 people have started prepping for the AKT, 4 haven't, 3 have a little bit. And for those of you who've started, so the vast majority of people, 11, are using past medicine. We've had a couple use on examination and 5 of you using GP self-test. And then we've got 7 for other. So do people who have said other want to unmute themselves and tell us what they're using? Or write it in the chat, whichever you prefer.
So I put other because there's no option for nothing, because you can only submit the questions if you put something for all of them.
Oh, I see. Okay, thank you for that, Hamza. I wasn't even aware of that. So other, that's a none. Anybody using a different, an alternative resource that I haven't mentioned?
Well, sorry, if you mean resource, I sometimes use Oxford Handbook of GP.
Okay, yeah, so Oxford Handbook of General Practice, yeah. And then Susie said the questions on the RCGP website and then reading around weaker topics. Denise has said reading around weaker topics through the Oxford Handbook, and Deepak, iMedics as other, but mainly past medicine and GP self-test. Okay, so there's a variety of resources being used. Okay, lovely.
I think I would like to add nice CKS for the common topics. Hello?
Sorry, Bummy, what did you say?
Yeah, I said I would like to add the nice CKS. It was very useful for the common topics.
Yeah, absolutely. Yeah, so absolutely. So using 9 sort of clinical guidelines, so CKS. Absolutely, that's really great. And we'll come to that in a second, but thank you for mentioning that.
Another thing that I've found is on Spotify, the RCGP has an e-learning podcast,
Yes.
which they've got from their essential knowledge updates for a few years,
Yeah.
which is quite nice, because I drive quite far to work. So,
Perfect. Thank you, Paul, for mentioning that. Yeah, we're going to mention podcasts in a second, but I agree. I'm a big fan of using podcasts as learning on the way to work. And did you find that helpful, Paul, in your revision so far?
Yes, a little bit. They're not very comprehensive podcasts. I haven't sort of looked for any other ones or paid for anyone specifically, but these ones sometimes highlight things you haven't thought of. They're not so good for revising a whole topic, though.
Yeah, okay, lovely. Okay, so for those of you who haven't looked into the exam, I'm going to do a couple of slides just about preparing for the AKT and what it is, some useful resources, and then Tom's going to take us through some top tips as well. So a reminder for those people who haven't done the exam, it's a computer-based exam, which is 3 hours and 10 minutes or 190 minutes. Out of that, you've got 200 questions, and 80% of them, so 160 questions, are clinical. 10% of them are evidence-based, so 20 of those questions, and 10% or 20 questions around primary care organisation and management. So if you think about the sort of things that you might need to cover, the clinical base is around essentially the whole breadth of the GP curriculum. So that's about the symptoms, the signs, the investigations, the management of common GP topics. The evidence side is an area that people get quite worried about, and I was certainly really worried about it before I revised. And that's around statistics. It's around interpreting your basic graphs and statistics, but at a level that a normal GP should know if they're looking at journals or reading the newspaper or talking in a meeting. So it shouldn't be anything rocket science. You know, it shouldn't be rocket science. And my top tip for that is, I think we mentioned it last time, is do a bit of work, learn the equations, make sure you can do the questions, maybe, I don't know, a month or two before the exam. If you need to forget about it, and then revise it again the week or two before the exam. Because if you're like me, for this sort of information, my head is a sieve, and even to write the questions today, I had to go back and re-look at everything, because I couldn't remember it. Primary care, but you had your stat session that Henry did for you, so hopefully that's provided you with a good foundation. And then, as I said, 10% is around primary care organisation. Now, those are things that when you see your trainers going into their room with a massive pile of paperwork, that's normally what this is about. So it's about sort of all the forms they're filling in, so the DWP and PIP forms. It's about death certificates, coroner forms. It's about Med3s. It's about QOF registers. It's about locally and direct enhanced services. So for me, this is a really good area to cover on a tutorial. Ask your trainer to save up some paperwork for a couple of days and start going through it. And I promise you, the number of questions and things you'll learn from it will be really good. And it's a slightly better way of doing it rather than just sitting and reading questions by itself. And as I said, it's there to cover the breadth of the GP curriculum, which we'll come back to in a couple of minutes. It's available to start doing in ST2. And normally when you want to do it is sort of a little bit up to you and where you are in your life and in your rotations. I did it, I think I did it in my second half of ST2. So I did a 6-month psychiatry post where I started revising for my AKT and then started general practice. And I gave myself about 6 weeks into general practice, and then I did my AKT. And for me, that was a good time. It was where I fitted into my life, and I had a bit of GP knowledge to consolidate the information with. So it is thinking about where it's right for you. We've got a slight issue with the fact that of COVID, so everyone's a bit delayed with doing it, and I'm sorry about that, and I'm really aware of that. I think if you're going into ST2 and you've got time to revise for it, it's a good time to do it in ST2 because you don't have then the stress of e-portfolio, work-based assessments, and your RCA to manage an ST3. But you also want to make sure that you have a short enough gap between doing your AKT and doing your RCA or CSA, so you don't have to revise all that knowledge again. At the moment, normally the AKT is just 3 sittings, so October, January and April. But obviously with COVID, they've introduced a smaller sitting in July and a larger sitting again in August, and that's for people catching up if they should have done their AKT and ST3 and didn't get the opportunity. You can take your AKT 4 times, and 95% of registrars should pass their exam within that 4th attempt. If you're doing it in July and August, then I'm sure you're aware that the AKT attempt doesn't count. There was something else I was going to say about that. It'll come back to me. If you have got a reason for why you need extra time, so something like dyslexia, for example, then the college will add on the extra time. You just need to let them know in advance, and they'll add on 25% of that additional time, but then you have to do it in the afternoon. So I'm sure most of you are aware, but the AKT questions, the exam is all done at the View Centre, the Pearson View Centre, so where you did your driving theory in the past. There are always a few people, or one person from every sitting apparently, that gets turned away because either they arrive too late or they don't have the correct ID. It sounds crazy, but it's still happening. So you need to take with you 2 forms of ID, so be it driving licence or your passport, and a credit card or debit card. And a credit card or debit card with your signature on. And it has to be the same name that you've registered in when you registered for the exam. There is a good 10-minute tutorial that you do before you start the exam, but that tutorial is available on the RCGP website. And I would advise anybody before the exam to do that tutorial. It's really quick, and it just calms your nerves a little bit about how the exam's set up and how the computer screen's all set up. The AKT questions are all written by GPs or TPDs, and the exams are all based around sort of low national guidelines. So there shouldn't be anything too crazy in those questions. At the end of the exam, the performance is scrutinised by sort of a psychometric team, and if anything goes out of, if anything is sort of slightly skew in terms of the performance, the psychometric team take it back to the examiners who review those questions, and then they may or may not decide to take that exam, that question out of the exam. So for example, if guidelines have changed and everyone suddenly sort of got that question wrong. So as a result, you might find that your exam's out of 198 or something instead. And that's just for that reason. What else was I going to say? When you do the exam, so each of the question is on there, it's worth reminding you that you can flag the questions for review. So I'll come back to exam technique in a second, but there is something there for you to flag, and you can come back to that at the end. It's worth working out how many questions you need to do in each time period. So if you've got 200 questions and 190 minutes, it works out as 57 seconds per slide or per question. So before the exam, it's worth working out how many questions that equates to for 60 minutes. I have written that down. So by an hour, you should have got through 63 questions. By 2 hours, you should have got through 126. And by sort of 2.5 hours, you should have got through 157. Because when they look at why people have failed the AKT, the biggest reason is because they just haven't got to the end of the exam. So they spent too long doing the first lot of questions. Okay, that's probably everything for that. Okay, so how do you sort of, where do you start really? And I think this is the biggest issue. So when I was revising, I was like, where on earth do you start? This, you know, you look at the GP curriculum, it's massive, the topics are huge. I think the important thing is giving yourself enough time. You need to treat it like any other post-CCT exam, so post-grad CCT exam. So you need to give yourself at least 3 months, if not a bit longer. As people have mentioned, there's some really good resources on the RCGP website. So there's a GP self-test, and I think Tom's going to talk about that in a little bit more detail. There's essential knowledge updates, which give you some quite good clinical-based topics with some questions on. And then you can have a look at the curriculum and see where your weaknesses are. I think a lot of people, me included, I always start my questions at the questions I know I'm going to get right. So if I'm doing a psychiatry job, I start my questions doing psychiatry because I'm like, oh, I can answer these, I can get these correct. And then suddenly we get a bit of a false sense of security. So it is worth looking at what are your weaker areas and maybe discussing that with your ES or your trainer. What rotations are you missing? Where do you feel you should start? And past medicine, it divides all those topics up for you. So you can just do the pediatrics, you can just do the obs and gynae if that's where you want to start. The RCGP has got an absolute mountain of information on the AKT section. So there's lots of tips about how you should go about doing your AKT. Most of them are in this presentation, but again, it's worth thinking about it when you're starting to revise for your AKT. Just make sure you've looked at all those sections on the RCGP website. And there are 50 sample AKT questions and answers. So again, they're well worth doing. Innovate journals, I think, are worth their weight in gold. They've got really good clinical based topics, and they've also got some good AKT questions in there. So if you're currently not reading your Innovate journals, I would start doing so, or just at least flicking through and looking at the AKT questions. Somebody said they were using 14 Fish. Who was or has used 14 Fish? Who was that?
I started using 14 Fish.
Yeah. How are you finding it, Chaluka?
It's good actually, because there are some like videos. So I found it very useful.
Yeah.
Yeah, it's more like a common topics.
Yeah. So for the AKT package with 14 Fish, I think it's about £95. And they do videos around clinical topics, and they've got exam technique, and they've got some exam questions on there for you. And I think you pay the money and then it stays with you until you pass the exam. Hopefully there will be some study budget available for 14 Fish. So if you are thinking about it, just double check to see if that study budget has become available. There was some chat about it. My biggest thing is tip is for you guys to focus on clinical based guidelines. So I would shy away from sort of big medical textbooks, because what you need to know is what you need to know as a GP, and as we all know, these textbooks become out of date very quickly. So as Bunmi mentioned, things like the NICE guidelines and the CKS guidelines are essentially a lot of what you need to know for this exam. So my registrars, I'm encouraging them now, they're on the phone with people. On one screen, they might have the patient's notes, but the other screen, they've got CKS up at the same time. So anything that they're doing, they're reading about as they go, and it will just help to consolidate that information. You make sure what you're saying to the patient's right. It helps you ensure what you're saying is right, but you're learning as you go as well. And then it's just practice, practice, practice. And I personally use past medicine. I liked the way that the questions were set out, but I also really liked the blurb underneath, and that's what I learned. And I use that with the CKS guidelines to base my knowledge around. A reminder to try those exam questions under exam conditions as well, if you haven't done that as well. And don't just focus on the ones that you get right. I always look for the ones I get right and then skip the ones I get wrong, and yeah, can't believe I actually passed it. So the other thing is vary your learning. It gets really boring just doing sample questions for 3 months. So as Paul mentioned, podcasts are really useful. So you've got the Innovate Sage podcasts, which are really good. The other podcast that I have on my phone, for all of you, if you haven't downloaded something called Primary Care Knowledge Boost, I would say that's one of my most useful learning resources. So it's two GPs who CCT'd a few years ago, and they every week just release a new clinical topic, which is it's normally discussed with either a GP with special interest or a secondary care consultant. But it's just got all those like random questions you ask as a GP, and it's really good. And then I'm sure a lot of you have already got, there's the RCGP podcast, and there's the NB medical podcast. So those are the ones that I often use sort of to reinforce my learning. Tutorials. I think if you're doing clinic topic based tutorials, then it's a good idea just to have some AKT questions sort of to help consolidate that knowledge. So for example, if you're asked to, you know, this week you're doing about men's health, you know, allocate maybe you or your trainer to go, actually, why don't you go on the Past Medicine and find us 5 questions about men's health, and do them before your tutorial, then do them at the end of your tutorial, just so you're consolidating that knowledge a little bit. And then it's up to you if you want to start study groups. I started doing study groups, but then I found them a bit overwhelming and I wasn't really learning anything, so I quickly stopped it, but it depends on what's useful for you. And then the RCGP have got some really useful feedback statements. So they'll tell you what the pass mark has been in previous exams, but they'll tell you where people haven't done so well. So again, that might be an area where you start to focus on. I'm sure a lot of you know about some of the courses, so I'm not going to go into that too much. Places where people forget the BNF. So I think the first 20 or 30 pages of the BNF are actually really useful to find out about scheduled drugs, controlled drugs, prescribing drugs, and that's quite generic, useful information if you haven't read. And then don't forget the DWP information, DVLA and CAA, so the aviation authorities, because those questions do come up. I've got a really good resource for DWP, so I will send that when I send the copy of this. I'm hoping it's recording, just made me think. When I send a copy of this presentation, I'll send you that resource. And then the other thing that I found when I was preparing this is the MDU and GMC websites have actually got some really useful information about ethics, consent and confidentiality, which it's quite difficult sometimes to find how to revise those frameworks, but they've got some really useful resources and they've got some useful clinical cases that again you can use for tutorial topics as well. And as I said, you use your tutorials. But again, you're all adult learners, you've been doing exams for a long time, you'll know how best to prepare for you and what works well for you. But those are just some suggestions, and I'm sure Tom will talk about those in a couple of minutes. So in terms of technique, I've mentioned about keeping an eye on the time. It goes without saying that, well, the exam is not negatively marked, so don't not answer a question. Have a go at it. You'll normally have an idea between 1 or 2 answers, so even if you don't know it, just have a go. Don't spend too long on a question. Know that you've got about 57 seconds per question. Flag those you're unsure about, because at the end of the exam, when you're about to finish, a screen will come up to say, these are the numbers that you've unanswered, and these are the ones that you've flagged. And if you get time, you can go back and flag them. Sorry, go back and review them. And the other thing is use the cover test if you can. So when the question comes up, cover up the answers with your hand, or I don't know if you've got a bit of paper in there, but cover up the answers with your hand. What would I answer? How would I answer that question? Is the answer there? Yes, it's there. Fantastic. And think, you know, use your intuition, use your gut as well. And I'm sure you've done these types of questions before, but essentially there are often single best answers or EMQs, so extended matching questions. And then there's some which might be free text as well, which might be more relevant for like drug calculations. This is just what the pass mark was back in January. So the pass mark was 67.5%. I think normally it's around sort of about 70%. And the overall pass rate for that sitting was 64%. And as I said, at the 4th attempt, most people have passed their exam, but you probably don't want to spend that much money or that much time revising. It used to be the exam that people used to pass, and we used to concentrate on the CSA, but now that's all reversed, and people are actually often more successful in their CSN. The whole country deaneries have seen an increase in failure rates for the AKT. So it is one of those exams that you just have to take seriously and revise for. And these are some of the common areas of weakness that have been mentioned in the last few feedback statements issued by the college. So bearing in mind things about drug interactions, drugs when pregnant, breastfeeding, safe prescribing, coroner notifications, childhood infections, childhood development, skin, fungi. I'm not saying just look at those completely, but they might be ones that you might want to start off, for example, looking at. Okay. So now, hopefully Tom has reappeared and is with us.
Yeah, I'm here. Hopefully that's better.
Yeah, that's much better. Do you want to, if I make you a co-host, let's see if that works, and then you can work through the slides yourself. I think, let's try that. Okay. So if we hear from Tom, and then we can answer anybody's questions. Okay, perfect. Are you ready, Tom?
Yeah, I'm fine. Just seeing if I can move that screen on or not.
Can you or not?
I don't think so.
Okay. Let me see if I can. I can't even see you. Show active speaker. Okay, you could maybe put your hand up or something and I can move it along for you when you're ready. Right.
Yeah. It should hopefully be fairly close.
Pardon?
Yeah, so I did my AKT in January this year. So that was the start of my ST2, sort of beginning part of ST2. So I've done, just from my last rotation in ST1 was psychiatry. So I started revising about the August time, and then I plan to take the exam in January, when actually I finished GP rotation in the early December, and then I just moved on to obs and gynae. So kind of just in terms of where things fell for me, it kind of worked well there. So in terms of what I use, so as Selena's mentioned, a few of the things that I kind of did use when I took the exam. So past medicine was the thing that I used the most, really. It's a huge question bank. I think it's about 4,500 questions altogether. And I just worked through all the questions that were available. Once you've finished them all, you can't go back and answer the ones you've got right. You can only go back and answer the ones you've got wrong. So it logs those ones, and then you can go back and retry the ones that you didn't get right first time round. It's really good question bank. It's very, very varied. And I think probably, if anything, if you, as Selena was saying earlier, when you're not really sure where to start, it's a really good starting point. The curriculum is so varied that it can be really daunting, thinking, oh, well, where do I start with this? What's the first thing that I choose? Where do I go? But if you just start with the questions, you soon find that you pick up areas that you're perhaps a little bit weaker in, areas that are your strong points based on your experience, etc. So I think basing it around that, I went for using kind of the potluck sort of method of answering questions. So I didn't choose any particular specialty, just worked through the questions, because I thought that kind of replicated the exam a little bit better. And then once I'd worked through them all, went back and worked on areas that I'd not done quite so well in. It's very accessible. There isn't an app for it on Past Medicine, but you can use it quite easily on your phone. So it's very easy to use if you've got like a break at work, or you're at home and you've got a bit of time. It's very easy to use, very user friendly. And probably the best thing about it is every single question, once you've answered it, has a blurb at the bottom. Now the blurbs don't really change. So they are, say you have a question on type 2 diabetes, for example, the blurb will be pretty much the same for every question on type 2 diabetes, which will be a rundown of essentially what are the nice guidelines for that. So it's worth just reading that every single time. So it gets very repetitive, but after you've done 4,500 questions, it kind of, you hope it sort of sticks in your head. So yeah, see if I can move this one. There's a couple of things that are perhaps drawbacks with it. I think sometimes, having done the exam, I don't think it always feels that the questions can be not as representative of the exam as some other resources that I've used. And actually, I would say that it probably is pitched. Some of the questions are more difficult than what I experienced in the exam. And a lot of it is some of it is just sort of rote learning of what the guidelines are, etc. So don't be too worried about your overall average percentage mark, because you might find that that's not an actual reflection of what your knowledge is. And when you use some other resources, you might end up doing a lot better, which is what I found. I found that when I went to use another resource, GP self-test, for example, I actually scored a lot better than what I was scoring on past medicine. So it probably is best to use it, as I say, as probably a base for your learning to build from, and then you can use and bring in other things as well. So RCGP self-test is probably the thing that I would recommend the most. I think use it with the past medicine question bank, but it was something I didn't really know about until I'd started revising, and actually only towards the end. And what I did was I did all the questions on past medicine, went back and covered some of the areas that I didn't do so well on. And then just before, a few weeks before the exam, I started doing especially time test on GP self-test. They really helpfully split them up into, you can split them up, I think it's 45, 60 or 100 questions. So one thing I did was the few days before the exam, I did myself the mini exam, as it were, just to try and get my timings right a bit. So I do say 100 questions in the morning, 100 questions timed in the afternoon, something like that, just to sort of get used to kind of what it would be like in the exam scenario. The questions are all written by the RCGP, and there was a few questions that I had that were from the self-test that were lifted directly from that and put word for word in the exam. I think at least 2 that I can think of off the top of my head. So you can see how that's more representative of what the AKT is actually going to be like. So yeah, as I mentioned, found a bit more useful to it towards the end with your kind of using it as a time test. And it's good to sort of use it as a knowledge check, just to see how you're getting on. So you might want to use it a bit before that and see how you go in comparison into another question bank, or use it towards the end and kind of get that used to it before you sit the actual exam. So yeah, as Leah mentioned as well, Nice EKS is probably the most useful thing, to be fair, in terms of other resources that aren't questions. It's obviously what the answers for the exam are based on. It's actually, I find quite intuitive and user friendly. And I did things, as Selena mentioned, for her registrars, when I was on my GP placement, even if I was familiar with the guideline and say, I don't know, it was a 2-week wait referral or something, and it was fairly obvious that it was a 2-week wait referral, I'd still look at the guideline, because it just consolidates that knowledge for you, allows you to look back on it, refresh your knowledge, you know, and then you can read about the whole of the guideline rather than just the bit that applies to that specific patient. It's just repetition, and it just helps to reinforce things. So yeah, I can't recommend those highly enough. I think if you're going to if you think about doing the exam and you're on GP, especially, get using the Nice EKS for sure. The BNF as well. So I went to this talk last year in August time, or maybe July, August time last year, when I was in ST1. And one of the things that one of the PDs recommended there was looking in the BNF, which is something I'd never considered before. Like Selena said, there's some really useful chapters just on prescribing at the start of the BNF. There's also some useful chapters on prescribing in chronic diseases, based on each chapter in there as well. So for respiratory conditions, cardiology conditions, etc. And I did the same sort of thing. So if I was prescribing something, even if I knew something that I'd prescribed, you know, a number of times before, I would have a look in the BNF, or have a look at the BNF online, just have a look, you know, common contraindications to that, reasons why you wouldn't prescribe it, you know, those sorts of things, because they're things that are really useful and do actually come up quite a lot. And you'll find that there's common themes of things that you really should be aware of that you shouldn't be prescribing together, for example, that come up quite a lot in the practice questions. So just useful to go over those things as well. So on YouTube, there are some, it might have already been mentioned, but there are some free videos by Aurora Medical. They also put things in podcasts which you have to pay for. I think it's about 20 minutes. There's a basic statistics video, which is free on YouTube, and that is actually really, really useful. The guy, he just goes through all the kind of basic things that you need to know, basic equations, really useful things on statistics that actually is probably the fundamental things that you need to take with you into the exam. You don't need to remember every single equation, but there are some that are more useful than others. So that's definitely worth a watch, I would say. So just some other things to think about, really. So obviously think about your learning style, as Selena mentioned. Obviously all adult learners, and we've all got our own way of learning. I find that I'm somebody who I think it helps me to write things down. Certainly helps me to, you know, write down the guideline, and then it helps reinforce it a bit better, or important bits of information and things like that. And then I did find that just doing the questions, and again, just reinforcing that, doing the same things over and over, and that repetition did allow me to remember things better when it came time for the exam. Think about when's the best time for you to take the exam. Obviously, you've got to take, you know, personal, family considerations, things like that into account, and also around your rotations as well. As I mentioned, for me, when it worked best for me was I had psychiatry before, then a full GP, 4 months of GP in ST2, and then I did my exam just at the beginning of obs and gynae. So although my obs and gynae rotation was a bit more, was a bit heavier in terms of the on-call work, I actually found, because I'd done that 4 months before in GP, I'd managed to sort of consolidate that knowledge over that time, and actually it was right at the beginning of obs and gynae, so I'd still had time to revise for about a month after rotating onto that one. So just things like that to consider, really. Definitely make the most of your GP placement if you've got one upcoming, or if you have had, you know, if you're on one at the moment. And I think that especially applies to the organisational aspects of the exam. There are questions on it, but it's a really easy way to talk to your educational supervisor, your clinical supervisor, other partners in the practice. Try and attend some meetings if you can. Talk to the practice manager, because they're the people that know about all the organisational stuff. So really just make the most of it. You know, try and make the most of the study leave and the time that you do have to do some things that you wouldn't be able to do in hospital, that are just going to help you with your learning. And some things you won't have even known that that's what GP entails, and you'll learn a bit about other things that you don't even think about when you're a registrar, but will definitely come up in the exam. So don't neglect the statistics. What I would say actually is, it's probably, what I found from the exam was it was much more based on evidence interpretation. So there was a lot more of, here is a graph, have a look at this graph, and how does it apply to this data, rather than asking you to remember what is the you know, the equation needed for number needed to treat, or those sorts of things. It was much more of, you need to apply your knowledge to this question, and, you know, how does the statistics fit with this. And like Selena says, you only need it to a level that a GP is going to know and be comfortable with. It's not going to need to be anything more than that. You don't need to know it in, you know, huge detail, but there are very important things. One extra thing, one little practical thing is, you do get Selena was mentioning about a bit of paper. You do get a erasable sort of whiteboard, little whiteboard, and you do get a marker in the exam. So one thing that I did, I had a couple of equations. So the sensitivity specificity table, for example, I had that in my head, and as soon as I got into the exam room, I just wrote it down on that bit of that whiteboard, and then it was there. I could look at it if I needed to. I could reference it, but I didn't need to remember it. So that was something that I found really useful. There are a lot less questions. It makes up less of the exam, but my best marks were on the organisational aspect of the exam, and then my second best mark was on the evidence interpretation. So it does show that if you do the learning, you can do all right with it. You don't need to be scared of it. Yeah, that's just what I've said, really. Yeah. So just have a think about timing. As Lena said, just if you flag the questions don't rely on too much on the time that you'll have to go back at the end, because it is really tight for time. I only had about 10 minutes left at the end, but you can go back. Do use the practice questions at the start. They're not marked, so don't expect you to kind of get an indication of how well you're doing at the very start of the exam, because you don't get a mark for it at all. But it is useful to settle your nerves and get you used to more familiar with how to use the software and stuff. That's it really. I think kind of that was probably some repetition from what Selena said, but any questions, anyone?
All good consolidation. Has anyone got any questions? Okay. There might be questions that
good.
There might be things that come up.
Yeah, it's fine. But yeah, you'll all be fine. It's actually, it's just something you got to do. So just put the work in, and you'll be fine.
Wise words. And the only thing just to add about past medicine is that I don't think I'm not sure how often they're updated. So just very occasionally, if you're reading something and you've got a question wrong, just have a quick look about the NICE guidelines that they've talked about, because there might be actually a more recent guideline that you're more aware of.
So a very practical example of that was the NICE guidelines for hypertension obviously changed last year.
Yeah, absolutely.
And they hadn't been updated even in January when I was doing those. Some of the questions had, but some of the questions hadn't. So on past medicine, there was still some of the questions where the answers were based off the old guidelines rather than the ones that had been changed last year.
Yeah, absolutely. Perfect. Okay, thank you, Tom. That's really helpful. Okay, so we're going to just take a little bit of a break, and Tom, I know you're working, so if you need to go, you're very welcome to head off. So we're just going to take a little bit of a break, and I want you to go and have a wee, go and grab some water, go and grab a cup of tea or something, and then we're going to come back and we're going to just spend sort of 5 or 10 minutes just doing a little bit of small group work, just because I'm very aware that you guys haven't sort of seen each other, and I know that a big Zoom platform isn't a great way to also chit chat. So we're going to go into small groups, and I just want you to think about what you feel are your challenges for preparing for the AKT and how you might overcome them. What resources are you using or have you used, or after today might you go ahead and use? And then if we've got enough time, we'll just try and collate some of those answers together. So just nominate one person in the small group who's gonna write them up on the whiteboard at the end. The only other thing I was going to say just about what Tom was saying about past medicine, if you just revise the information that is on past medicine, it's not enough information. And I'm sure you know that, but people just learn rope learn what's there. It's not enough detail. It's a really good starting point, but you have to use it to then look at CKS. That was the only thing I wanted to remember. Okay, so let's get you into some small groups. Okay. So do you know what you've got to, you know what you're going to talk about? everyone should be coming back. So I'd written these AKT questions and I'd had all the answers prepared. And then for when we did it last time, and now I've just obviously remembered that I can't remember where I've written any of the answers. I was just running around the house going, where are these bloody AKT answers? So if I look a bit like I have no idea what I'm talking about, it's because I can't remember the answer. So I'm gonna put it out there now. Okay. Okay. Hopefully everyone should be back. Okay, so what we might do is just, if you pick, hopefully you've picked one person from each breakout room, and we're going to try, I haven't used the whiteboard very much before, so we're going to try and use the whiteboard just to collate the key points, maybe any top tips that people had in their group. So maybe sort of one challenge, how they're going to overcome it, and perhaps sort of a useful resource that we've already mentioned, or something new that we hadn't thought about. So let's see if we can get this up. Whiteboard. Share. Okay, so if we think about who was in breakout room 1. Janice.
Yes.
Yeah, perfect. Janice, can you, I don't know, I've not done this before. Can you see the whiteboard, and are you able to write on it with your?
Oh dear. Okay, I did this on my phone, not my iPad or my laptop, so I'm not sure how
Okay,
well I'll do.
no problem. Okay, maybe I'll try it out for us, and then maybe the next person can give it a go and see if they can do it themselves. So what sort of challenges did you come up with, and sort of how you might overcome them? And if you got one top tip that we might want to share?
One of them was just the diversity of resources available. There's just so many things that keep on coming out, and this person used this and this person used that, and not knowing necessarily which one's the best. But I think, well, one thing that everybody agreed on was that nice CKS is basically the the benchmark, or the foundational piece that everybody can agree is useful. And as far as the question banks, to go with what works with your style of study best. Quite a few people were keen on past medicine, but that's in our group. But at the end of the day, you basically, and the idea was, it's better to pick one and engage with it properly than to dabble, because this one said this is good and this one said this is good, and then find yourself sort of at the end having, excuse my French, half-assed 10 different question banks.
Yeah, I completely agree. There is so much available out there. Just pick one or two and go with it and do them well, rather than half-heartedly doing a bit of everything. Absolutely. You were having a very excited conversation about something though, Janice. What was that?
I was telling them that if you go on the Sage publications, all the AIT questions have been gathered, like the AIT AKT style questions have been gathered. So if you want to be very cheeky and not read your AIT magazine, but you want to still get the questions, there are about some 700 questions at last count.
Perfect. Okay, thank you. That's very good. You do have to sign a non-disclosure before you go into the exam, so just a reminder. Okay, breakout room 2. Who was in breakout room 2? Anybody? Hamza, which breakout room were you in?
I was in 5, I think.
Okay, we'll go with 5 then. So what sort of challenges did you come up with?
So I think we just talked more generally about plaques, and none of us have sat it, so we were still kind of very early stages in terms of thinking when to sit it, and then planning 4 months back from there. So I think we were just talking about the uncertainty of the second wave of coronavirus, and obviously if things get thrown up in the air again, whether or not kind of sitting it sooner is better. I think Kat's in a bit of a tricky position because she's not got a GP for another year, which is similar to me as well. And it's just about, we were just talking about timing and how to kind of, I think it's just a case of planning it in a way that if things do get thrown in the air, you can still kind of use what you've revised usefully.
Yeah, absolutely. I mean, I really feel for you guys because you are in a very difficult situation, as in the uncertainty going forward. So the college have put in plans for sort of July and August, and then are planning for October. But yeah, you're absolutely right. If there's a second wave, who knows what will happen? They will have to come up with one way of doing it or another. I'm sure some of you are aware they haven't even sorted out how they're managing shielding trainees. So but they're going to have to find a way, because I don't think it can be delayed for much longer. Yeah. Okay. Well, that's a useful point to bring up, and thanks for bringing it up. I don't think there is a right answer. I think you just have to do what fits in best with your life, don't you, and where you can fit in your revision and hope for the best. I know some people here were really disappointed their AKT was cancelled in, was it March or April, on the day of their
April.
Which one?
April.
April, on the day of their exam, it was cancelled. So they'd done 3-4 months of revision, and then, yeah, very frustrating. Okay, Mahmood, which one were you in? Mahmood?
Sorry, hold me. You mean which group?
Yeah.
I don't remember. Was it number 3? Or...
Okay. What sort of challenges do you come up with in your discussions?
So, so I was with Kat, Susie, and Hamza.
Are you with Hamza, were you?
I was with Hamza.
Maybe we've already heard from you guys there.
Yeah,
Did
you were 5 with us.
Sorry? Did you have anything else you wanted to add, Mahmood, then?
No, sorry, I wasn't able to hear. There was some problem with the voice. I wasn't hearing what was said. If Hamza spoke, so he's representative of us. Then.
Okay, fair enough. Right, who else have we got? Susie, what about you guys? Which one were you in?
Sorry, was that me?
Yeah.
I was in 5 as well. I'm really sorry.
Anything else from another breakout room?
Yeah. So
Paul.
Kat, Susie, and Hamza.
Okay, Paul, go for it.
Yeah, we were group 4.
Yeah. What's the challenge you come up with?
I think some things we identified is the sort of magnitude of the workload. So even just doing one resource like past medicine, 4,100 questions. And, you know, even if you were to think of doing them at test speed of 57 seconds per question, that just takes up so much time. So planning about how you're going to get through all those questions is a lot of work. And then if you look at the list of CKS topics letter by letter, you know, it's just an overwhelming amount of topics that you can see on that website. And I think one thing we suggested is that you pick areas you don't know so well, because there will actually be a lot of things that you do know, and try and revise those with priority, and then other things opportunistically, and using your practice as much as possible. So when you see a patient, read up on the topic, or if you don't see topics much, if you see another GP seen somebody, check what they did and check the guidelines and things like that.
Yeah, perfect. So using sort of everyday experiences to learn a little bit as you go.
Mm.
And as I mentioned as well, like if you're doing any learning, so you know, if it's tutorials or things, thinking about how you can incorporate a bit of AKT revision into your tutorials. We're gonna try a new thing for you guys going forward in August, is that we're gonna assign each of you, so ST1s and ST2s, it depends if you've moved to ST3, an AKT topic. So we're going to start every session with maybe a couple of slides about a clinical topic, and then a couple of AKT questions, so maximum of 10 minutes. But again, it's just giving you a bit more exposure to some of the topics out there, and a few more sort of forced AKT questions. That'll be something that will come in August, just as a way of trying to get you thinking about your AKT from an earlier stage. And did you have any other suggestions about resources, Paul? Or Paul's group? I know you mentioned you were talking about CKS quite a lot, weren't you, in your group?
Yeah. I think that we were saying that's also sort of the foundation. Not to get too sidetracked by other things, but the guidelines are kind of what you need to know clinically.
Perfect, thank you. Is it Uzaya? Uzaya, is that? I heard you talking quite a lot about different things. So what sort of challenges did you guys come up with?
Had different discussions about, it was general discussion. We did not basically discuss any particular point, because I appeared before in the last examination as well, and I did talk about that we need more time to prepare, at least 3 to 4 months. And the resources, there are many resources, and everyone have different mindset, and whichever suits them, that including one-day courses of eMedica or Aurora, AKT courses, and then statistic course as well, that I paid for last time. But the session we had, I think few weeks ago, it was more useful and more clear cut comparing to that session that I paid for.
Okay.
Yeah.
And are the courses useful? Do they just go through, are they useful in things that you wouldn't be getting if you were working yourself, or is it just something else to consolidate knowledge?
I think if you have less time, then you can think about that. But if you have 3 or 4 months, I don't think they are that much useful. It is just your own confidence.
Okay.
It depends on that, yeah.
Okay, thank you. Which group have we not heard from? Shalika, did we hear from your group? Maybe Chalika's gone off. Francesca, you with Fran, you with Chalika, weren't you? Have we heard from your group?
Yeah, no, you haven't. We were mainly just talking about what's already been talked about, like the uncertainty surrounding COVID. And I think TG was like the concern when you sort of built up to an exam and then it was cancelled, trying to maintain that, like all of the things. But we were talking about, they've mentioned sort of the DVLA and stuff, was what we'd already mentioned, but that was sort of, the challenge was the uncertainty really, which I suppose is kind of a bit out of our control.
Yeah. Okay, thank you. Have we heard from every group? Yeah. Is there anybody else, anything else that anybody wants to add, or any other questions whilst we've got, especially whilst we've got Tom here as well, before we move on to our practice questions?
Delina, can I just ask a quick question?
Yes, please do.
Did you say that the sittings in July and August don't actually count as part of your 4 attempts?
Yeah. But that, yeah, but that would only be for people who are going to CCT in sort of September or January, so in the next couple of months.
Oh, right, okay, fine.
So that's just a representation of actually how messed up things have been for people. So they've said that for the RCA and the AKT, that those attempts wouldn't count.
Fine, thanks.
All right.
Just another question.
Yes.
Is it just right to ask, in terms of like study budget and stuff, do you know if we get like any sort of help with the past medicine or anything else? Like what's in the study budget? Because I'm aware like all the resources like super expensive, the exam's super expensive.
Yeah.
Our GSC is super expensive before I spend too much money.
Yeah, absolutely. I don't know what is available on the study budget. I don't think past medicine, someone who's done the exam might be able to help, but I don't think past medicine is on there. But it is, I think it's about £40 for 2 months, or it's £60 for 3 months or something. I can't remember. So it's not a huge amount of money. But as I said, 14 Fish is going to become part of the study budget going forward. Is there any, Tom, can you help with that question?
Yeah, I think so. I think I'm right in thinking that if you, I think Selena's about right with the prices for past medicine. It's not hugely expensive. I think it is about 60 quid for 3 months, and all the question banks are about the same. The thing that seems to get expensive are the courses. I think some of the courses they do charge a lot of money for. I know that the AKT course, I think, is it the AKT Saturday? You can, if you failed the AKT, you can go on free, I think. but if you've had one attempt, I think you can go on it for free. But other than that, you might have to pay for things like that. I didn't find that there was any sort of study budget at the moment, but obviously that might change. I'm not sure.
All I've heard is that they're going to hopefully introduce the 14 fish to some study budget.
I'm sorry, what about BMJ on exam? Because I went to the Chesterfield Library and they had it for like MRCPs, and they used to have it for MRCGP, but they don't anymore, like for the AKT.
They removed it.
What exam?
They used to have BMJ on examination. They used to have it as a resource before on like for free through the library, through our program, and they don't anymore. And I'm not sure why.
I don't know. You mean for revising for the AKT exam?
Yep.
I don't know, but I can try and find out for you, Janice.
Yeah, because I asked the library and then they said that, you know, it was removed.
They didn't for AKT. Yep.
I can try and find out for you, but I think I don't know. It might for all the resources I've looked at when they've talked about from the college and things, they haven't mentioned that as one of the resources to use. So it might be that's just gone out of flavour a little bit.
Okay.
Okay. Any other questions? Okay.
Just one other thing. A few questions in our group about the curriculum, about if anybody sort of ever looked at the curriculum and they found it useful, or how sort of in terms of studying from the curriculum on the website at all.
Does anybody got any comments about how they feel about the curriculum?
It's too much. It's a lot. I don't know, there's like a poster, there's a poster from Aurora, but I don't know if anyone used it, but I don't know if it's useful because it's the same with the curriculum. The curriculum is really a lot, and you know, yeah, there's a poster there I can see. It's just going to the past medicine, and then in past medicine you have like all the contents and you just read each one, but yeah.
When I started revising, I started with the curriculum. So I wrote out all the topics for the curriculum for each like curriculum heading. And then after a couple of hours, I was like, this is ridiculous. I'm never going to get through these things, and just found it completely overwhelming. So I quickly abandoned it and just went using the topics that came up in past medicine and CKS. So personally, that's how I did it. And I used what I was reading about and seeing every day in surgery. That's how I did it. I just found the curriculum too overwhelming. It's useful for maybe the bigger topics. But it might not be as sort of user-friendly as we'd like.
Yeah, because in the curriculum it says headache and then abdominal pain. You know, it's a lot. It's just generalized. So, and then there's a new curriculum now, which is still the same, still a lot.
Yeah. Does that answer your question, Paul? I think we're probably all feeling the same.
I think everyone just avoids it because it's not like a studying tool really. It's just a policy document, I think.
Yeah, I sort of agree with you. Amy, were you going to say something?
I was just going to say, can we maybe circulate the curriculum or something? Because I don't know if I can find it very well on the website.
Yeah.
Would that be okay?
Yeah. So I'll send you out afterwards. The things are all being recorded, and then they're also coming on our YouTube channel. Woo-woo. But I'll send you out the curriculum from the college. I'll check about the BMJ. I was going to send you something about DWP. And then as we're going through, if there are any other useful resources that you guys go, where's that come from? Where is that? I can send you that. What I've done actually is I've put together 2 or 3 pages for our registrars at our practice of useful resources for GPs that I use every day. So if you want to, I can send you that, because I think that's quite useful. That's like what I would look at for like contraception, what I look at for menopause and stuff like that. So I'll send that out to you as well. Okay, lovely. What we might do then is we might go on and start this sort of practice AKT questions. if everyone's ready to do so. Somebody's asking, do I need to attempt the questions as I've passed AKT in January? So there might be, I think there's about 2 of you that have already passed your exam. It's up to you. I still learned a lot from doing the questions. Tara's looked at them and she said she would have still learned a lot. So it's up to you if you think you'd get some CPD from it. I suspect there'll be something that you learn from it, but if there's something else that you'd be preferred to be doing, i.e. some e-portfolio or something useful, then you're very welcome to leave and go and do that. And Tom, if you're going, thank you very much for joining us and presenting. Okay.
Yeah, I do need to get back, sorry. But,
no, it's all right. Nice to see you. Thank you very much.
That does sound useful though. Can you, is it possible to circulate the questions as well?
Yeah, it's all going to be recorded and sent out to you, and it will all be on the YouTube's channel.
Yeah, yeah, thank you. Hope it goes all right for everybody. A bit of a weird time, isn't it? But it's hard to know what to do. But cool.
Thank you,
all right,
Tom.
thank you.
See you later.
You're welcome.
Bye.
Bye.
Okay, so guys, what we've done then is I've just put together 50 questions, and I've given you, hopefully, it should be on a timer of 57 seconds per slide. I'm going to keep quiet for them, so I want you to do it like you're doing in the exam in terms of reading. Use the cover test if you can, if you've got access to that, or, you know, cover up those answers. And I just want you to log what your answer would be. If we'll do 10 questions and then we'll do 10 answers. I'm going to run through the answers with you. I'm not going to do too much teaching just because we'll be here till midnight. But if there are sort of key things, we can sort of discuss it, and I can, as I said, I can send you the useful resources afterwards. All right. Right. Oh, right, annoying, it's gone straight to that. So you need pen and paper, guys, and you might use a little calculator as well. Is everybody ready to go? Okay, so round 1, here we go.
I'm writing an exam.
think this might be the longest I've ever had to stay quiet. It's killing me. And it goes without saying, just try not to look anything up whilst you're at home revising. Oh, whilst you're at home doing this. Oh, sorry, that might have gone a bit quick. I think I accidentally pressed a button. Okay, we're going to move on to the answers. Okay, so we're just going to whip through those first lot of 10 answers, just so it's not so many to go through right at the end. How was that for sort of 10 questions, 57 seconds a question? Feel all right?
Yeah, it's okay.
Yeah. It's all right if you know. It's all right if you know the answer, isn't it? Like you can do it within a couple of seconds. So I suppose the lesson is if you know the answer, answer it quickly and get on to the next one. Yeah, and then you can save a bit of time up for those ones that you need to have a bit of extra time. So I think I whipped through questions quite quickly, and my mistake that I sometimes make is I don't read the question properly. So whip through them, make sure you've read the question properly. In particular, look for that word that says not, this is not a risk factor, or this is not relevant, or something like that, because those are the bits I always miss. I whipped through the exam really quickly, but even Mia only had time to go back to the flagged questions. So again, it's tight on time, even though 57 seconds felt quite a long time there. Okay, so we're going to go through those questions, answers. So an 82-year-old man, become confused, see him on a home visit, urine's clear, he's a bit confused, sodium's 126, rest of his blood's unremarkable. The medications that might be the culprit, they all cause a hyponatremia. Okay, so you can mark yourself right or wrong for that. Okay, 48-year-old has the Kylina device. So I've given you what device it is there. I don't know if that will happen in the exam, so you might need to just make sure you know what the common IUSs and the IUDs are. Inserted on day 8 after the start of her cycle. How long will it take until she can rely on it for sexual intercourse according to FSRH guidance? So the answer is 1 week, because it's being put in after week 1. If it was put in within the first week of her cycle, it would be okay to be used reliably for contraception. 2 days, that would be for something like the progesterone only pill. So 52-year-old diabetic, HbA1c is 64 and he's already taking 2 grams of metformin, he's on a statin, his BMI is 32. What would your next management step be? So it would be start glycoside, 40 milligrams. He's already on the maximum dose of metformin, so that's not an option. Insulin and exenatide, you wouldn't probably want to start because they are third line, or if you couldn't tolerate sort of oral medications, then that's why you might start it. So an 82-year-old man currently taking 30 milligrams of MST, BD and some paracetamol. He's having breakthrough pain and the district nurses want some Oromorph. The correct dose of Oromorph to prescribe is 10 milligrams. So his total dose is 60 milligrams of morphine a day. So the breakthrough dose is 1/6 of his total. So that's 10 milligrams of Oromorph. So hopefully you should have identified that diagnosis is seborrheic dermatitis. So the first line treatment would just be some topical ketoconazole. Okay. So 4-year-old is rushed into practice with a fever and non-blanching rash. You're worried about a diagnosis of meningitis. What's the correct dose of benzyl pen IM to give to this child? So the correct dose is 600 milligrams. So a 1 to 11-month-old baby would be 300 milligrams. 1 to 9 years would be 600 milligrams, and then above that would be 1.2 grams. 64-year-old bus driver is discharged following the diagnosis of TIA. How long is the minimum he cannot drive for according to the guidelines, DVLA? So he's a group 2 driver, so the minimum he can't drive for is for 1 year. If he was a group 1 driver, it would be a month. Okay. So a 52-year-old Nigerian man has the following ambulatory blood pressure readings. So his average is at 159/89, and his Q risk is 10.8. His ECG, fundoscopy and urine are normal. What's the next best step according to NICE guidelines? So it's start amlodipine at 5 milligrams. So he's Black or Afro-Caribbean or under the age of, sorry, or over the age of 55, it would be to start a calcium channel blocker. Match the picture with the correct diagnosis. So this is a picture of pityriasis rosacea. So that is a viral rash. It's often confused with tinea, and I'm sure a number of us have treated them with antifungals, and actually they just need time and sort of 6 to 12 weeks for them to settle down. What you can see on here, the reason why hopefully it should give it away, is you've got a typical herald patch there on the picture. So that's a larger lesion that often starts before the rest of the rash appears, and patients will often say, yeah, it started with this one here that's quite big and then it's spread everywhere. So that will be a herald patch, and that's sort of definitive of that diagnosis. And they've often got, whereas a fungal are often scaly throughout the lesion, your pityriasis is often sort of just more scaly around the border of the lesion, and that's another way to identify the difference, to find the difference between the two. And then for this one, the answer is 100 micrograms. So some nice guidelines came out at the start of the year for hypothyroidism. So I always really struggled with what is the correct dose. So the guidelines were it's 1.6 micrograms per kilo, and then round it to the nearest 25. So you've got a 68 kilo person. So 68 times by 1.6 is 108, and then I've rounded it to the nearest 25, so that's 100 micrograms. Okay, everyone all right? Everyone alive?
Yep.
Good. So just put a number next to how you did out of that 10.
Where?
Just on your piece of paper, just so you can write, just so you can collect
what?
it at the end.
That's like asking my age.
You're not sharing it all with me yet, so don't worry. Okay. Right, we'll do another 10 and then we'll have a little bit of a comfort break. Okay. So round 2. Oh, sorry. Oh no. Right, that's my fault. Did you all get that? We might need to do that one at the end. Let me stop clicking. Okay. Now, right, let's go back to that one that we missed. So can you all see that question? I'll just give you sort of 20 seconds to have a look at that. Okay. Okay, so we'll run through those answers, guys. So 70-year-old man discharged following an elective cabbage 2 weeks ago. How long can he not drive for according to the DVLA? So the answer is a month. So just mark if you've got that right or wrong. What is the correct treatment regime to give improving H. pylori according to NICE and Public Health England? And he hasn't got any allergies. So the answer is number 1. So that's lansoprazole 30 milligrams twice a day, and amoxicillin 1 gram twice a day, and metronidazole 400 milligrams twice a day for 7 days. The reason why I sort of hopes it would be slightly easier is because that's the only one that's got a PPI twice a day and is for 7 days. So hopefully that should have given you a slightly better indication that that was going to be the one to go for. So school exclusion, don't know how easy this is to see. So this is an area where people don't always perform as well. So mumps is after 5 days of treatment. Scarlet fever is 24 hours post antibiotics. Scabies is after treatment. Whooping cough is 48 hours post antibiotics. And hand, foot and mouth, you don't need to be excluded from nursery, from school or nursery. Okay. And you'd only just get 1 mark if you got them right. This is a useful thing that I have on my wall, which again I can send to people if they find it useful, because again this is something that doesn't come into my head very easily and I forget and get a bit confused about. So it's quite a useful thing just from PHE about when kids should return to school. So 74-year-old chap's got some clinic blood pressure readings and you asked him to go and do some home readings. What's the correct advice you give him with regarding timings? So it's 2 consecutive readings, 1 minute apart, twice a day for 4 days, ideally for 7, and discard the first day of your readings. So that's something that we must ask people to do on a daily basis, but I'm not sure how many of us actually know what the NICE guidelines are for doing home blood pressure readings. So that's what it is. Okay. And it'll be worth having a look at your surgery pro forma and see if it fits that guideline, if it fits those guidelines. So 24-year-old got diagnosed with asthma. She's currently taking some Ventolin and using it sort of 2 or 3 times a week, 2 3 days of the week, yeah. And she's also taking some Clenil, so she's already on an inhaled corticosteroid. You've checked her inhaler technique and she's using a spacer. What's the next step according to NICE? So I've said it was stop Clenil and start some Foster, because she's already on a moderate dose of an inhaled corticosteroid. So we can't add in Foster because that's a combined inhaler, which is a long-acting beta agonist and an inhaled corticosteroid. So you can't add it because she's already on Clenil. Can't increase the Clenil much. So the best thing is to stop her Clenil and start a combination inhaler. Qvar is another inhaled corticosteroid, but it's just got extra fine particles. But you might swap Clenil to Qvar, but you're not going to add in the Qvar. And Spiriva is a LAMA, so a long-acting antimuscarinic, which is used for COPD but not for asthma. So Mrs. James is an 84-year-old lady who's returned to surgery with home blood pressure reading. She's currently taking aspirin, amlodipine, some bendroflumethiazide and statin. Her blood pressure readings have an average of 144/84. What's the next step? So for her, the next step is to reassure. So her blood pressure readings are slightly above what you would want for anybody else having home readings, but she's 80 or above. So actually she still fits criteria because her blood pressure readings are less than 145/85, which is what's on the NICE guidelines if you're 80 or above. 52-year-old requests HRT for night sweats, flushing and irritability. her blood pressure's okay, and her BMI is 30. She's got migraines, and her cousin's got breast cancer. She's had a hysterectomy already. She's come to you requesting HRT. What's the single best option below? The best option is LS Solo. So Vagifem, it doesn't say about her topical symptoms, but it's not going to affect her systemic symptoms. Femston, Fem7, and Promeka are all combined HRT. So she doesn't need to have the progesterone, she only needs to have the estrogen because she's had a hysterectomy. 10-week-old baby's got worsening reflux, and you want to give him some ranitidine. What's the right dose of the ranitidine? So the dose of ranitidine is 1 milligram per kg. The child weighs 5 kilos, and you've chosen to prescribe ranitidine 150 mg in 5 mils. What's the correct volume? So the correct volume is 0.15. So it's 5 divided by 150, and then times it by 5 by 150, and then times it by 5 by 150. Now I've forgotten. What's the correct dose? Right, let me work this out in my normal way of doing it. I've written my notes down which are wrong.
Yeah, 5 times 1, and then you times with the 150
Yeah.
divided by. Oh, no,
I think it's 5 times 5 over 150. That'll give you 0.15.
Yeah, 5 divided by 150, and then times it by 5 is 1.6. Yeah, it's being an idiot. So yeah. So I still work out like I worked out my basic arithmetic. So 150 milligrams in 5 mils. So then I do 100, and then 5 divided by 150, and then times by 5 because that's the weight of the child. So you should get to 0.16. I've rounded down to 0.5. So how soon is it safe to fly after the successful drainage of a spontaneous pneumothorax, presuming you've got full lung expansion? So according to CAS, it's 2 weeks. I was pretty surprised about, but there we go. So 35-year-old woman is 28 weeks pregnant with a second child, and she's gone on to have an oral glucose tolerance test because she's got a family history of type 2 diabetes. What the results are: a fasting blood glucose of 5.7, and she's got a 2-hour glucose level of 7.9. The results indicate that she's got a diagnosis of gestational diabetes. So according to NICE, if you've got a fasting blood glucose of 5.6 or a 2-hour level of 7.8 or greater, then that's diagnostic of a gestational diabetes. Okay, how's everyone feeling? Do people want a bit of a comfort break, a bit of a stretch? Do you want to jump up and do a couple of star jumps? No, yes. Why don't I show you that? I'll show you a little video and see if this wakes people up. Who's saying something? Okay, so we've got a couple of yes to comfort breaks. Okay, good. All right, so it's 4 o'clock. So why don't we just say that we'll take 5 minutes. So we'll meet back here at 4:05, and then I've got 30 more questions. You don't have to do 30 if it's too much. At least we can do sort of 20 of them. If you want to do the last 10, you can do the last 10. All right? Yeah, so see you in 5 minutes then. Okay. Okay. Right. Let's run through those answers whilst they're fresh in your mind. So choose the single best contraception in the following scenarios from the list below. I've tried to make the scenarios pretty obvious, but I think what somebody was saying, the trade names might be what's tripped you up a little bit. So 22-year-old lady is currently using the combined contraception pill, and she attends for a pill check. And she's found to have a BMI of 30, and she's never smoked, but she's troubled by moderate acne. So my feeling was the best thing would be switch her to Yasmin, which is a slightly more it's slightly more effective on acne rather than sort of your band or combined contraceptive pills. A 48-year-old lady with hot flushes, keen to consider HRT. She's sexually active and is married with 2 children. So she still needs a form of contraception. So the best choice for her is going to be to go with the Mirena. So that's a progesterone coil, because that will handle the progesterone form of the HRT. 25-year-old lady recently had her 2nd child, attends her 6-week postnatal, and keen to start a form of contraception today. So I think the best one would have been to give her Sorel there. I suppose you could argue you could give her a depot while she's in the room with you, but I think most of us would hand out a prescription for a progesterone-only pill, which is what Sorel is, or Cerazette is otherwise known. Okay, so single most likely causative drug for each of these. So hypoglycemia, the most likely drug is glycoside. Flatulence is metformin. Swollen ankles is amlodipine. Cough is perindopril. And indigestion is alendronic acid. Okay.
Selena?
Yeah.
I'd argue that also insulin can give you hypoglycemia.
Oh yeah, you're absolutely right. Well done, friend. Yeah, you're absolutely right. So that might be one of those where, where if people have put sort of both questions and answers, and a lot of people have put them, then it might be one of those that goes back to the examiners and they have another look at it and say, actually, we'll accept both answers, or we take it out completely. But you're absolutely right, yeah. Okay, so 72-year-old man is found to have this on his ECG. What tool may be used to risk stratify with regards to anticoagulation? So it's Chad's Vasc, so hopefully everyone's got that right. Which of the following consultation models is housekeeping advocated? So it depends on how much consultation models you've done previously, if you'd get this right. But it might be one of those things that you end up just learning, rote learning with past medicine. So the answer is neighbour. So that does the 5 stages of this sort of consultation model. So that's the connecting, I'll see if I can remember it all now. Connecting, summarising, handing over. I've written them down somewhere because I knew my memory would go. Connecting, summarising, handing over. My memory's gone. I'll have to come back to it. I've written it down somewhere.
Is it safety netting?
Safety netting, thank you. And I can't remember the 5th one either.
Housekeeping.
Yeah, handing over, so timekeeper. Is it time? Connecting, summarising, handing over, safety netting, and
Housekeeping.
Housekeeping. Yes, well done. It should have been my basics. I should be able to remember. Okay, so 74-year-old seen with a possible TIA. History of hypertension. His blood pressure is 142/90 today, but he's otherwise well. And noticed a weakness in his right arm, which will last approximately 15 minutes. What's the most ideal management as per NICE guidelines? So according to sort of ABCD, which I don't think they actually go with anymore. Actually, I think NICE has sort of moved on from that. I always used to calculate that, but I think now they've said give them some aspirin and refer them to be seen within 24 hours, unless they've got multiple risk factors or it's still ongoing where you might want to admit them now. So which of these is not part of the UK MEC3 guidelines for prescribing the combined contraceptive pill? So the answer is history of a blood clot, because that would take them into UK MEC4. So just a reminder about UK MECs. 4. So 1 is that there aren't any issues. 2 would be that the benefits generally outweigh the risks. 3 is that the risks would outweigh the benefits. And 4, you wouldn't go there, it'd be completely contraindicated. And if you haven't seen the FSRH guidelines and the UK MEC, they are worth having a look at, and I'm afraid they might be just one of those things that you just need to learn for the exam. So a 24-year-old attends to discuss some antenatal counselling, and her older sister has just had a daughter with cystic fibrosis, and she's concerned regarding her risk of having a child with cystic fibrosis. She and her partner are both well, and she's unaware of any other family history of cystic fibrosis within the families. What is the risk of having a child with cystic fibrosis if both her and her partner are carriers. So it's 1 out of 4. So I've just written it down there for you, the next slide. So I'm sure all of you can remember these diagrams from med school, but obviously you've got sort of, I should have labelled it up, but you've got sort of maybe the partner and the patient. So if both of them are carriers, they've got one dominant and one recessive gene. So I've just done my little graph there, and then you can see that the double R is the child who's going to have cystic fibrosis, so it's 1 out of the 4. And then you've got a 2 out of 4, or 50% chance of them having a child that's a carrier. Then they've got a 25% or 0.25 chance of having a child without any, without being a carrier, or without being a carrier or without being affected by the disease. That's also a common thing for CSA, or used to be a common thing for CSA as well. So that's the other time your genetics pops up when people come in for genetic counselling. So 28-year-old presents with a temperature, mild rash, and has got this on their cheeks. What's most likely virus causing it? So it's parvo, it's slap cheek. Okay. And 34-year-old lady is 4 months postnatal after having her first child, and she's breastfeeding, and she's got some low mood and symptoms of depression. There are no safeguarding or safety concerns, and you make a diagnosis of moderate depression. She's declined involvement with mental health services, and I asked what's the safest option to use. So the safest option to use if you're going to go through with medication is normally an SSRI, and sertraline is the one that's often the agent of choice that's deemed to be the safest in breastfeeding. And again, there's BUMPS is a useful website or resource if you haven't got that one for pregnancy and breastfeeding, if you need in practice, for example, to look up things. And then the last one, so what's the most appropriate treatment for this condition? So that's into trigo. So the most appropriate treatment is going to be some topical clotrimazole. All right, that hopefully shouldn't be too bad. Okay, so I'm just gonna show you this quick video just in case you're bored and need waking up a little bit. Right, how do I get rid of that? Okay. Let me just see if I can get the Zoom up again. Okay. So this is just a, you've not seen, I don't know.
What have we got?
RTA, broken arm, suspected internal injuries, severe contusions to the head.
Okay, let's move fast. Put me a solution of arnica montana. Stat.
Strength?
1 part in a million.
I'm sure, it looks serious.
You're right. We need to strengthen all those. 1 part in 10 million.
On it, doctor.
Then we've got a tricky one. That one we can't handle. Get me some wolfsbane, also known as monk's hood, in here. And a whole tray of flower remedies.
Oh, the chakras are fading. I need some crystals.
Nice. Fresh some purple tinted quartz. Right. Make that aquamarine quartz.
Good call.
Okay, it's stabilizing. Now, does anybody know what sort of car hit it?
Blue Fort one day, apparently.
Right, get me a bit of blue for 1 day. Put it in water, shake it, dilute it, shake it again, dilute it again, do some more shaking, dilute it some more, then put 3 drops on his tongue. If that doesn't cure him, I don't know what will.
Look at this, Simon.
What is it?
This poor chap's got long to live.
Why not?
His lifeline, very short. His horoscope's not too clever either. Sagittarius. Brace yourself for a surprise. Things are about to change for you.
Certainly are, unless... Wait. Right. We could try drawing a bit more lifeline on with biro. Work. You got a better idea? Let's see what happens. Death, 334.
Tough day, eh?
I just can't stand losing them.
It happens.
I don't know. Sometimes I think a trace solution of deadly nightshade or a statistically negligible quantity of arsenic just isn't enough.
That's crazy talk, Simon. Okay, so you kill the odd patient with cancer or heart disease, or bronchitis, flu, chickenpox, or measles. But when someone comes in with a vague sense of unease or a touch of the nerves or even just more money than sense, they'll be there for a bottle of basically just water in one hand and a huge invoice in the other. I suppose you're right. Yeah, I'll drink. I need one. Excuse me. 2 more homeopathic lagers, please.
Well, that's strong stuff.
Right. We've got so I've got another 20, but I don't know how everyone's energy levels because it's really warm and it's a bit exhausting, is it? Should we just go with the 10?
I'm afraid, sir, we still have a problem with Detective Harris.
Yes. Stop
Mr.
that.
Harris.
Yeah, should we just go with another 10? I can't see anybody.
Yeah, that'd be fun.
Yes, yeah.
Yeah.
Share screen. I can, oh God, I can send them all out to you though, so you can do the others if you want to in your own time. I suppose it was just more just to give you a bit of an idea about what some questions might be like and what your knowledge levels are like at the moment, where you might want to start focusing on. Okay, here we go. Okay. So 64-year-old lady comes to see with some spirometry results. So she's increasingly short of breath and she's an ex-smoker. So her heart rate's okay, her saturations are okay, her peak flow's okay, probably. It's not horrendous at 450. And what we've given you is FEV1 and FVC, and then the ratio. So the key bits of information here are that the FEV1 and the FVC are both reduced, but they're reduced in proportion. So it gives you sort of a normal or sort of higher than normal ratio. So it would suggest a restrictive lung condition. So pulmonary fibrosis is the only one on there, bearing in mind she's got a normal peak expiratory flow rate. And again, if you haven't looked at sort of geeky medics, I think that's quite a useful one for spirometry interpreting. So for this lady, her FEV1, so the amount of air she can blow out in a second is reduced, and her forced vital capacity, so what she can get to at the very end when she blows out, is also reduced, but they're done so proportionately. So that would suggest, as I said, it's a restrictive condition. So to get to the ratio, I just did 250 divided by 300 is 0.83. I was doing this and then I started to question myself if I'd got it right. So I don't know what you guys have said. So it was supposed to be a bilateral sensory neural deafness, or basically suggesting somebody who had bilateral age-related changes. So as you can see, the higher the frequency, the lower they are at, the less good they are at hearing. And that's in both those ears. So the circle is the right ear perhaps, and the cross is the left ear. And again, what I've done there is just put some examples of, because I'm not going to teach audiograms now, but if you wanted to go and just have a look at some examples, which might be useful for your AKT or just in general practice, it doesn't happen very often. We don't do audiograms in our current practice, but I used to in my old practice. I used to occasionally get sort of audiograms shoved under your nose. So it's a useful one maybe just to have a look at. Which of the following is not a reasonable reason to exempt a patient from QOF? So deemed not appropriate to review chronic parameters due to age. So you can't exempt somebody from QOF because of their age. You might exempt them if they're very frail. So frailty would have been appropriate, but age wouldn't have been appropriate. And the others are reasons for why you exempt somebody from a QOF register. So this is, I think, something that sometimes people don't do so well at. But again, I think it's something that you maybe just need, it's one of those things that maybe you just need to learn. And this is the resource that I put on there, is quite good. So it's basically a short guide to the benefit system for GPs. You couldn't get a better resource, and it's really quick and easy. So a 29-year-old care worker working 14 hours. So she would be suitable for universal credit. So universal credit is supposed to cover the cost of living if you're on a particularly low income. 69-year-olds low income or working less than a certain number of hours. 69-year-old lady with metastatic breast cancer who's deteriorating. So hopefully everyone got that. That's DS 1500. 54-year-old lady with severe rheumatoid arthritis who is increasingly struggling. So that would be your PIP. And that is replacing your disability living allowance. So it's for people who've got long-term conditions or disabilities or difficulties managing their ADLs. And that's going to be, and they've at least had them for 3 months, and then they can apply for PIP. And a lot of you might have PIP forms to fill in at work. A 36-year-old medical secretary who's unable to work due to severe flare-up of IBD. So SSP is statutory sick pay, she'll be able to get. Oh, doesn't want to move on. Okay. A worried mum brings a 5-year-old to surgeries, is still wetting the bed at night, but it's been dry for the last 2 years. Which of the following are not part of the NICE guidelines? So a trial of desmopressin would not be appropriate at this time. So 5 years old, you probably wouldn't be expecting him, you know, it would still be okay up until probably the age of 7 for them to have some nocturnal enuresis. And there are definitely things that you would want to try beforehand. So ensuring they're adequately hydrated, not drinking too much, a trial of without nappies to see if they just get it, and a reward chart. A 54-year-old, symptoms of UTI, urinary frequency and urge. She's tried some lifestyle modifications and she's still symptomatic. There's nothing else to find on examination, and a urine dip is NAD. So what's the initial first line treatment? So for somebody, you would be trying them on conservative or lifestyle measures if they've got something like an overactive bladder in this case. So that would be 3 months of pelvic floor exercises. And then after that, you might give them a trial of medication.
Salina, sorry.
Yes.
3 month pelvic floor exercises or bladder training, because it's like an overactive bladder.
No, you're right. Sorry, Luca. Yeah, you're absolutely right. Thank you. Bladder training. Yes, ignore that one. I was bound to get one of them wrong at one point. I'll change that. Thank you. I just highlighted the wrong thing. So 54-year-old lady has CKD3 without proteinuria. His current medications are aspirin, statin, ramipril, and metformin. His latest eGFR is 38. According to the BNF, what is the best course of action with regards to metformin according to the BNF? So with that eGFR, according to the BNF, the best course of action is to reduce the dose of metformin and recheck the user needs, as opposed to stop the metformin. And again, that's when we mentioned sort of reading, some of the initial chapters or the common medications is useful in the BNF. Pre-COVID, in which of the following circumstances would you not be required to refer a case to the coroner? You can select one or more cases. So you wouldn't have to refer a death occurred within 3 months of an operation. You would have to refer it if the death occurred in the operation, but not within 3 months. A 64-year-old man presents with sudden painless blurred vision in his right eye. The following is found on fundoscopy. So this is retinal vein occlusion. So you've got a blurred optic disc, you've got hemorrhages, and you've got some small, smaller bleeds there as well. So that, along with the history of a man, older, painless blurred vision, would suggest a retinal vein occlusion. And the correct treatment for this rash, so that's erythema migrans caused by Lyme's disease. So the correct treatment would be oral doxycycline. And that's a target lesion there. Oh, a bullseye lesion even, sorry. Thank you, Chaluka, for correcting me before. I think I'd...
It's okay.
Okay, right. We were going to skip round 5 and we're going to finish. You'll be happy to know, because it's been quite tiring, especially because it's so warm outside. Right, so just to get an idea of how you guys have done. So you might just want to count up how you've done. It's anonymous, so you don't. So we won't know who's done what and how well people have done. But if you wouldn't mind just sort of counting up and saying maybe where you've got into with those numbers. So obviously it's only 31. It's only out of 40. Okay. There's one more person. I'll go for it. Okay, so yeah, so great. We had 3 people who could score between 31 to 40, and the vast majority between 21 to 30, and then a few 11 to 20. So that just might give you a good idea of where you are. But you know, if you're ST1 and you haven't done general practice yet, or you haven't done general practice for a while, then that might explain some of that. So I definitely don't want anyone to worry about their results. Hopefully it's just giving you an idea about some AKT questions that I've randomly made up, so you can blame me. And also it's just giving you an idea maybe about a couple of areas that you might be a good starting point for you to work on. So hopefully that has, and hopefully as we've gone, we've suggested a few resources, and I'll pop some of those in an email for you, and I'll just send it along with the recording so you can have a look at that in your own time, and hopefully you'll find some of those useful just for everyday working as well. All right. I'm sure everyone is roasting. I'm absolutely about to collapse with big heat. So I'm sure you're all feeling the same. But I hope that's been all right. And I hopefully, you know, you've managed to get a couple of useful resources out of it. You've had some chat about discussing how some of you might be sort of tackling the AKT. And I hope some of those questions have been useful for you. They've been useful for me. I've learned lots doing them. So. All right. Is that okay for everybody? And we look forward to seeing you next week. All right.
Can I just ask, you know, the last time when you have the lecture, you have this book that you were telling us that you will send the link or the book thing, you know, about the out of hours, where you share about your experience regarding about what normal saline to give to patients with, you know, for syringe driver, something like that.
That wasn't me, because I don't think I've done anything about out of hours. Was it somebody else, or when was the teaching done, Michelle?
I think that was you were doing the introduction for the AKT something statistic. You're doing the AKT, the first one.
Oh, I see.
You know, that book that you were showing to us, that you're using for out of hours. You're saying, like, you know, your experience about out of hours.
I don't do any out of hours. That's why I'm a bit confused about the book.
Okay,
does anybody else remember, or was it?
Maybe I'm wrong. Fine.
Was it the purple book that palliative care used to make?
Yeah, was it? Is it just the palliative care book handbook?
Yeah, I think that's the one.
I don't think it was me that was mentioning it, but I can have a look, see if it's available online, because basically they stopped publishing them and printing them, but it's a fantastic palliative care handbook if you haven't seen it.
Yeah, because I think it's interesting, you know, when we are going in for out of hours, we don't know about the syringe driver and what do we mix with those medications, you know, for palliative, something like that.
Okay, I'll have a look for it and see if I can send it to you if it's the handbook I think that you mean.
Thank you.
All right. All right.
All right, thank you.
All right, take care. Bye.
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 Bye.